Good morning, everybody. I'm going to talk about different procedures and some convictions related to assisted reproduction. And I believe many of the procedures we are doing and many of the drugs we are giving are not really evidence-based, and many of them we can do very well without and save a lot of money and effort. The real practice, doctors generally try to work using evidence-based medicine. However, many procedures and many drugs used have been used extensively for years and years and still are being used extensively without any proof that they are really of a value to the patient. I'm going to just take few points related to assisted reproduction. What about ovarian stimulation? Most of us abandoned already doing basal FSH assays, which we continue to do for 30, 40 years, and we thought that this is the best test for ovarian reserve. Now, this test does not tell us very much, because if the FSH is very high, okay, then the patient have a very poor ovarian reserve or already menopausal. But a normal FSH does not mean anything. The patient may have a very poor ovarian reserve and you will have a normal FSH. And then you have to make the test at specific dates in the very early period of the cycle, so you may wait a whole month to do the test. And I believe, and it seems, that in the future the basal FSH testing is really in doubt and will not be done in the future. All of us are using FSH hormones, different forms of FSH hormones. Some people use recombinant, some people use urinary, some people use purified urinary, and some people mix them together, give one drug and another drug to the same patient. There is no proof whatsoever in the literature that this is right. All these drugs are the same. Mixing them is based on no. In America, they do mixing a lot. It's based on really no proof and no science which says, so we choose the cheapest one, taking care of the condition of our patients. For many, many years, we thought, and we think still, that clomiphene is a drug which has really stood the test of time. It has been used very effectively for now more than 50 years, 55 years. And this drug is very useful, very effective, very cheap, minimal side effects, and we continue to use it. And the previous reports suggested that letrozole and clomiphene, they have the same efficiency or equal efficiency, and we used the cheaper one, which is clomiphene. But recently, this paper was published in the New England Journal of Medicine by Legro, where a double-blind, multi-center randomized study, large study for 5 cycles, the cumulative live birth rate was significantly higher in the letrozole arm, 27% versus 19%, and the difference was significant. You remember the early reports on letrozole showed increased incidence of congenital malformations, but this was denied in repeated reports afterwards that it is safe to use letrozole. In this large study, the arm of letrozole, there were 4 major congenital anomalies, and there was only one anomaly in the clomiphene arm. The difference was not significant, so the conclusion was there is no increased incidence of congenital malformation, but we should take care, and I think bigger studies should be done to exclude for sure that letrozole is associated with congenital malformations. Most of centers, including ourselves, are using lots of drugs during ovarian stimulation for IVF. Many people are using aspirin. There is no proof whatsoever in the literature that this is going to improve the IVF outcome or IVF pregnancy rate. No proof in many studies that it has any value. Antibiotics, doxycycline, again, no proof that it is going to improve the pregnancy rate in several studies. Cortisone, different forms of cortisone, again, it is of no value to use cortisone in IVF or during stimulation. And estradiol patches, many other drugs are used, and actually there is no proof that any of these adjuvant therapies, different forms, is of any use for the development. Poor responders, growth hormone has been used for a long period. Growth hormone, 3 meta-analyses showed that the co-treatment with growth hormone improved assisted reproductive outcome in poor responders. There was no increase in the number of oocytes when you give growth hormone in these studies, together with stimulation. But the pregnancy rate was significantly higher. The difference was very small, very little significance. But probably if it is producing a real effect, it is by an effect of the quality of the oocytes, not the number of the oocytes. But we should remember that growth hormone is extremely expensive. So you should do really cost analysis before embarking in giving growth hormone in these patients. Almost everybody in Egypt, and about 25% of all IVF centers in the world, they give DHEA during stimulation of poor responders or older women. Beyond any doubt, it has no use. DHEA, many studies were done, and the use cannot be currently recommended. No data from many studies that this drug has any effect or is going to improve the pregnancy rate of IVF. In poor responders, in general, and elderly patients, we should always know that the outcome, whatever we do, is very low. And as you see here, the live birth rate is only 6%. And the total cost per live birth is 80,000 euros, 88,000 euros, which is almost £1 million, £1 million Egyptian pound for one baby in these poor responders. So we should know this, that these patients in general have a poor prognosis. And this is very important in counseling. Women above the age of 40, again, the clinical pregnancy rate in general is poor. In this study it is 12%, live birth rate 10%, and from our center, live birth rate 6.7%, and only 1% for women above the age of 43. So embarking on IVF or ICSI or anything at this age, 42, 43, 44, and all this, actually you will have very, very little chance. And in the last publication of ASRM on the pregnancies report, annual report on on the whole United States, the pregnancy rate was, at the age of 44 was 0. We all, and many of us are doing IO intrauterine insemination. We should know exactly what are the possibilities, what are the success rate in doing intrauterine insemination. And in this very large study from the Netherlands with almost 20,000 cycles, the mean pregnancy rate was 9%, and the ongoing pregnancy rate was only 7%, and 10% multiple pregnancy rate. And the pregnancy rate in the Netherlands, 9% was comparable to that in international literature, which is the same. So don't have very big expectations from IOI. You can achieve some pregnancies, but the chances are little. And IOI, without stimulation, the pregnancy rate is very, very low. This literature, these results occur when you give stimulation and monitoring plus IOI. And this is the IOI results in the ESHRI 2014. The delivery rate was 9%. The twin rates again was 10%. And the triplet rate was 9%, which is very, very high and very risky. This should be considered when you do IOI. What about IVF and ICSI? What about luteal phase support? I know that everybody in this room who is doing IVF, or in many parts of the world, they give luteal phase support for many weeks after the occurrence of pregnancy, ignoring this beautiful randomized study, old study from 2002 from Copenhagen in Denmark, when 300 patients were randomized to give 600 milligrams of vaginal progesterone from E2 to the day of beta HCG. Those patients received the normal luteal phase support. And then on the day of beta HCG, when the beta HCG is positive and the patient is pregnant, you know that the patient is pregnant today, 2 weeks after embryo transfer, patients were randomized on that day into 2 groups. One group received stopped progesterone on that day, no more progesterone on the day of positive pregnancy test, and the other group continued progesterone for 3 more weeks. And the result was the miscarriage rate was exactly the same between the 2 groups, and no significance. This means from this study that giving any luteal phase support after the day of beta HCG is completely useless. However, we know very well that patients will refuse to accept this, to stop luteal phase support, and the doctors will be scared to stop because the patients will blame them that if abortion occurs, and we know that abortion rate is not very little after IVF, because they stopped the treatment. So, but we know this. We did another study which was published in Human Reproduction in 2008, and in that study, women from ICSI, again, they were randomized. Once we continued luteal phase support until we saw the heartbeats by ultrasound. On the day we saw the heartbeats by ultrasound, we randomized the patients into, again, 2 groups, and the same numbers, and the miscarriage rate again was the same in those groups. So we said for sure, really it is more than enough to continue luteal phase support, even it is not evidence-based, till the day of heartbeats, but not more than that, particularly when the patient is having intramuscular injections of progesterone, which is very painful and really troublesome. Triggering ovulation by GnRH. We know that if you are using GnRH antagonist protocol, you can trigger ovulation by HCG, or you can trigger ovulation by a bolus of GnRH analog to induce rise of endogenous LH, which will result in ovulation. From many years, almost 10 years now, it was clear from this study that when you give GnRH analog, you will have a lower pregnancy rate. You will have a definitely lower pregnancy rate. The reason why you give GnRH to avoid ovarian hyperstimulation syndrome. And truly, when you do this, you will have a lower incidence of ovarian hyperstimulation syndrome. Definitely, giving this bolus will reduce the incidence of OHSS, but also will reduce the incidence of the chances of pregnancy in these patients. Many studies are published particularly from Denmark, during the past 5 years about how to improve the pregnancy rate after giving this GnRH by giving small doses of HCG, by giving bigger doses of progesterone, estrogen, lots of things, many papers and protocols, but truly from this Cochrane review, which this is 2011, but it was updated last year, and the same results from this Cochrane review, OHSS rate was significantly lower when you trigger ovulation by GnRH. However, the pregnancy rate also is lower. Whatever you do, so far, the pregnancy rate is low. Frozen embryos and the number of embryo transfers. Since vitrification developed, and we know more about transfer of frozen embryos, the pregnancy rate following frozen thawed embryo transfers improved a lot and is higher, to the extent that some centers are only using frozen embryos, and they do not transfer fresh embryos, and they believe that it results in a higher pregnancy rate. This is, of course, not the consensus among the majority of centers, but there are people who are producing very, very good and high pregnancy rate for frozen thawed embryo transfer. A week ago, I listened to a Canadian doctor who is from a center who is only doing frozen embryo transfer and giving very good results. What about single embryo transfer? The data shows that double embryo transfer has a significantly higher pregnancy rate than single embryo transfer. But double embryo transfer is associated with high twin pregnancy rates and higher complications during pregnancy. In Northern Europe and in some centers, they are using now almost routinely, or at least in a good number of patients, a single embryo transfer to avoid the multiple pregnancy. This works very well if there is a national health service is covering the IVF center, because this is acceptable to the doctor and to the patient and to everybody. But if the patient is paying out of her own pocket, she does not want to reduce the chance of pregnancy by transferring only one embryo. Maybe if all centers achieve very good results with frozen thawed embryo transfers, then the policy will be more improved. Endometrioma. Very often we see endometrioma. Shall we remove the endometrioma or we leave the endometrioma in place? There are 3 randomized studies which showed that no significant difference in live birth rate between women with endometrioma and women with no endometrioma. So there is no idea to remove this endometrioma. And women with endometrioma have a lower number of oocytes, maybe higher cancellation rate, but no significant difference in the live birth rate. Removing endometrioma, particularly in the hands of not very clever surgeons or laparoscopists, have a very dangerous impact on the ovarian reserve. Even in very good hands, measuring the anti-malarial hormone level before and after, you will find decrease in the AMH level. And generally speaking, if you have a 5 centimeter endometrioma or less, better you leave it and proceed and go to your IVF and don't touch these patients. What about fibroids? Intramural fibroids, of course, subserous fibroids, no relation to infertility or outcome of IVF. Submucous fibroids should be removed, and the whole discussion is about intramural fibroids. There is a problem with studying intramural fibroids because there are no real randomized studies in this topic, and many centers, including ours, tried to do a randomized study many years ago. It didn't work. It didn't work because the patients who wants to be pregnant by any way, if you tell them, if you remove the fibroid, maybe you improve, okay, I remove it. The patient who does not want to have any surgery will always refuse. If you tell her we don't know, she will refuse to be randomized. So nobody was able to do this study so far to answer this question. But intramural fibroids without endometrial cavity in a large number of study, but observational studies and maybe controlled studies, the live birth rate was significantly lower in the presence of fibroid, and removing the fibroid improved the pregnancy rate, but this is not based on the really high-grade evidence-based medicine. What about heparin and IVF? There is no proof whatsoever that giving heparin to your patient will improve the results of IVF at all. It doesn't work. These have been done repeatedly in very good, well-randomized studies. It doesn't work. So no idea to give heparin. What about in this randomized study, which includes also a meta-analysis, they received heparin versus placebo. There was no difference in the clinical pregnancy rate or the live birth rate, and of course adverse effects was not reported. Maybe there were some adverse effects because of injection of heparin. Again, heparin and aspirin has no effect on recurrent miscarriage. Patients who with repeated abortions, giving heparin, giving aspirin, giving both does not improve the continuation of pregnancy and the live birth rate. Even with the patients with antiphospholipid syndrome, in a big study it didn't work. So it has no value in all cases, no use, but we in this room, maybe half of you are giving heparin to your patients. Maybe in our center we are giving by some people, but the fact is this does not work by very well randomized studies, and no benefit of anticoagulant on the live birth rate, regardless which anticoagulant, nothing. At present, there is no evidence that the use of anticoagulants in repeated miscarriage, even in the presence of inherited thrombophilia, is effective. However, we need more randomized studies for some patients. Maybe we will come out in the future with something. Progesterone in repeated miscarriage, no use. Multi-center randomized study, progesterone, patients with previous recurrent miscarriage, you give micronized progesterone, no use. Patients who will miscarry will continue to miscarry, and who will continue pregnancy will continue pregnancy, irrespective. Again, it was proved long ago that giving progesterone in what was called threatened abortion is totally useless. Patients who are bleeding in early pregnancy, I know everybody is giving this, and sometimes he has to give it because the patient is pressing the doctor to take something. But we should know it is completely useless. And this is the last study giving progesterone or placebo for repeated miscarriage, and the live birth rate, there is no difference in both cases. What about male infertility? There are 3 Cochrane reviews. The first Cochrane review was published by our chairman, Hans Evers, were 8 randomized studies comparing varicocelectomy versus no surgery, and he showed in that study that there is no evidence and no benefit from doing any varicocele surgery. The same Cochrane review was updated few years later, 10 studies, and there is evidence from that study that varicocele may improve couples' chance of pregnancy. However, the evidence is low, very low evidence, not guaranteed. And then, what about the future of varicocelectomy? All andrologists feel a prospective randomized study on varicocelectomy is important. Everybody believes that a large, good study, multi-center study is important to answer this question, whether really we can do varicocele or not. There are some evidence in the literature that doing varicocelectomy will improve the semen quality, the number of sperms, but not the pregnancy rate. And our aim is the pregnancy rate, not to improve the count or also. So there was a planned study, big study, because we know that almost all the studies are retrospective, very poor quality, and the randomized studies are conflicting, and they are methodologically poor. So that study was planned in 2014, large study, microsurgical varicocelectomy versus no treatment in the biggest andrology or urology centers in the United States. However, all the 5 centers failed to recruit adequate number of patients, and the study was stopped and cancelled. And the reason was lack of interest by the urologists. Many of the urologists were not interested to do the study. Previous medical treatment, some patient wants to have medical treatment rather than surgery, and it looks like that there was lack of interest by everybody, the patients, the doctors, so the study was stopped, and we will not really know the results. Now I'm going to talk about pre-implantation genetic screening. I know 3 people in this room will not approve what I'm going to say. Raga Mansour, Sue, and Laura Rinizi. I don't know if she came or not yet, but she may be coming, because I heard them all talking about this topic. We know that 10 years ago, PGD was introduced on day 3, 8-cell embryo, for more than 20 years ago, or even more, introduced for diagnosis of special chromosomal abnormalities, special situations, patients with a history of a disease or a special diagnosis, and that proved to be very important, very effective in preventing many births of many babies with different chromosomal abnormalities, single gene disorder, lots of things. And then the idea of making pre-implantation genetic screening, when 10 years ago it was started, the idea was that there are a number of embryos which are abnormal. If you take one cell, you will find that they are not euploid. They have a problem with the number of the chromosomes. So why implanting or putting in the uterus bad embryos? Why not choosing the good embryos with the proper number of chromosomes and putting them? Then theoretically, you expect better pregnancy rate and better prognosis and so on. And why not doing for everybody so we improve the pregnancy rate in general? And that was a really fantastic, theoretically fantastic idea. But when these procedures were done, and there are many early studies which were encouraging people to do PGS for all patients, then the randomized studies came from Belgium, from Holland, which showed clearly that this procedure is not improving the pregnancy rate, and on the contrary, it is decreasing the pregnancy rate, and nobody now is talking about PGS, pre-implantation genetic screening, for day 3 or 8 cell. Now, recently, there are new modifications, introduction of new technology, which you can examine not only 4 or 5 chromosomes, but the 24 chromosomes. And this examination, you could get the result 1.5 days, or etc., or maybe 2 days, microarray, or there are newer systems which will give you result faster. In few hours, you can get the results of the chromosomes. The idea here is you wait till the blastocyst stage, and you take cells from the trophoctoderm cells, and you examine them, and finally, you are supposed to transfer one single blastocyst, good blastocyst, euploid with normal cells in these patients. There are many studies which are done in different parts of the world, encouraging studies suggesting the use of this technique. But now we come to the evidence. All agree that using the cleaved stage fish is not useful or cost effective. This is finished. Everybody agrees on this. Now, we had big hopes that the time lapse where we observe in the laboratory the growth of the embryo, the division of the embryo, we can choose the fast growing, the best embryo, the good embryo. This will improve the result. But again, the studies lately came and said that this is a beautiful thing, but it is not going to improve the pregnancy rate, and of course it is expensive. This is the time lapse. No difference. There are 3 randomized studies. It is clear. Now we come to the PGS studying the 24 chromosomes. There are several studies. Most of the studies are not randomized studies, are observations.